if you're like me, you're hitting your metabolic nadir just about right now, so a little audience participation. My friend Lawrence Sen always asks questions like this, but he didn't do it today. I actually held myself back from doing it earlier. What is special about today? Pi Day. Right. Today is 3/14/15, like 3.1415, and at 9:26 and 53 seconds tonight, it'll be 314159265 and it won't happen again for another 100 years, so it's a special day. And I can think of absolutely no way, no matter how contrived, to tie it to today's talk. So I'm going to talk to you about labor epidurals and maternal fever. This is a topic that's very near and dear to my heart. I have no financial relationships to discuss, although I should note that the Society for Obstetric Anesthesia and Perinatology is going to be funding some of the work from our laboratory in this regard, and so I'd like to acknowledge their support. I also will be, in fact, discussing some off-label drug uses in this talk. All right, so to set the stage, epidural anesthesia usually cools people off. We have known this for a long time. It's not surprising physiology. This is a study in volunteers, not pregnant patients. If you look at the open circles, this is a measure of core temperature. Along the horizontal axis, you have elapsed time, and at time 0, an epidural was dosed. So patients just sort of sat there, the subjects, for 3 hours. Then they dosed the epidural, and they cooled off. The open circles go down. That's not surprising, right? We know that the sympathectomy of an epidural causes vasodilation, blood shifts from the heat shifts and blood shifts from the core to the periphery where it can be lost to the environment. Not surprising at all, very well understood physiology. It's just that that doesn't happen in pregnant, laboring patients. Again, labor is different. So about 25 years ago, Fusey was the first to observe this phenomenon. So you see here the temperature curves over time, temperature on the vertical axis, time on the horizontal axis, of women who self-selected their analgesia, either epidurals or, it's a UK study, pethidine or meperidine, in the dark filled circles. And you can see after a lag of about 4 hours of measurements, the epidural receiving patients slowly started to warm up. And I say slowly, if you look at the rate of this change, it's only about 0.07 degrees centigrade per hour. It's very slow, gradual rise. Now, Fusey measured temperature with a vaginal temperature probe. And some people criticized this work and said, well, of course, we know there's vasodilation at the level of the epidural block, and that's all you're seeing here is vasodilation from the epidural. So Bill Kamen and colleagues at Brigham and Women's repeated the study, this time using tympanic temperatures, which should avoid that problem, and they saw exactly the same phenomenon. So again, these are self-selected anesthesia. The dark circles along the bottom are patients who selected either nothing or intravenous opioids. The two, let me see if I can point. The two curves going up are the patients who received epidurals, one with and one without opioids in their epidural mixture, and you see exactly the same phenomenon. After a lag of about 4 hours, there's a slow gradual rise, about 1/10 of a degree per hour, in the epidural patients, not seen in the non-epidural patients. Now, this was one of those kind of scratch your head physiologic curiosities, who cares, gosh, isn't that interesting? And people were speculating about thermoregulatory dysfunction due to the presence of an epidural, until a few years later when Elise Lieberman was the first to say, no, this isn't just a slow gradual rise of 1/10 of a degree per hour, it's actually overt fever. So this was an analysis of a retrospective reanalysis of a negative randomized control trial in which patients self-selected their own analgesia, and this is a comparison of patients who received an epidural in the blue bars versus patients who did not in the green bars, and the vertical axis here shows the percent who had fever greater than 38 degrees versus different lengths of labor on the horizontal axis. And you see, irrespective of the length of labor, there's a lot more fever in the epidural group than there is in the non-epidural group. Now, Lieberman was the first to observe this, but lots of other people have observed the same phenomenon. We're not going to go through this. All you need to look at is all these 10 studies of observational studies with various definitions of fever and various patient populations all show more fever in the epidural column than in the non-epidural column. And if you look at the p-values on the right, they're all significant. Now, people still criticize this idea and said, no, look, that's just an artifact of selection bias, that is, who gets epidurals, they already have other risk factors for getting a fever, like slower labors, they're nulliparous, they have longer rupture of membranes, they get more cervical exams, what have you. But it turns out that that's not all there is to the story, because other study designs find exactly the same phenomenon. So this top study by Yancey, and I met somebody from Tripler Army Hospital in Hawaii where this study was done, was a sentinel event study. So in this study, the epidural rate in 1 year went from 1% to 80% when there was a military mandate that you had to provide epidural analgesia on demand, and not just for the general's wife, but for anybody. And so the epidural rate suddenly soared, and what they saw was a big increase in the incidence of fever, defined either as low-grade 37.5 or high-grade 38. In addition, as a secondary outcome, in about 8 randomized trials randomizing women to get an epidural or something else, there's also excess fever. A meta-analysis shows the relative risk is between 3.5 and 4 times as much fever. And so I don't think we can dismiss this phenomenon. This is a real phenomenon. There is more fever in women who receive epidurals. Now, this leads to the next question. Were those original observations by Fusey and Kamen, that slow, gradual rise, and this overt fever seen in the observational and randomized trials, are they different, or is that the same phenomenon? That question has been answered by reanalyzing the fever curves, the gradual temperature curves, rather, in women with epidurals. So this is some data from our own group. The blue bars the blue triangles didn't have an epidural, the red squares did have an epidural, and it looks just like those original studies I showed you, a slow gradual rise in the epidural group, not seen in the non-epidural group. But let's take away the non-epidural patients and just look at the epidural patients. It turns out this is not a homogeneous group of patients. There's 2 distinct groups here. One group never goes on to get clinical fever, and a smaller group, around 20 or 25%, does go on to get a fever. And if you plot their temperature curves, the ones who eventually get a fever versus the ones who never do, they look like this. So the graph with the triangles along the bottom now is patients who never get an overt fever, and their temperature is not rising gradually or otherwise. Whereas the other group, the ones that eventually get a fever, is rising. It starts higher, it increases faster, and if you average them together, you get the original curve. So the answer is there's really just one phenomenon, not 2. The Fusey-Kamen observation from the late 80s is an averaging artifact. The real money is in understanding why 20 or 25% of women with an epidural get a fever. So here's where we are so far. Epidurals increase temperature on average, but that is an averaging artifact, and it's really due to the subset that develops clinical fever, and that is not an accident or a bias associated with who gets epidurals, but a real phenomenon associated with the epidural. There was some allusion to this during the CSE debate. It doesn't really turn out to matter very much what kind of epidural technique you get. You get the same amount of fever pretty much all across the board. So it doesn't matter whether you begin your epidural early or late in labor. Gigantic randomized trial by Wang and colleagues done in China, no difference. It doesn't matter whether you dose the epidural intermittently or continuously. It doesn't matter if you do a CSE technique or a regular technique, and that analysis has actually not been done that often in the randomized trials, but in the 2 that actually looked at it, no difference. And it doesn't even matter if you don't do any epidural drug, if you put all the drug intrathecally. So the study by Tian and colleagues was continuous catheter-based intrathecal sufentanil, also found just about the same incidence of fever. So the real phenomenon here is neuraxial block. We don't really know why yet, but right now where we are is any neuraxial block, any technique is associated with excess fever. Why? We don't actually know, but among the mechanisms that have been proposed are thermoregulatory mechanisms, especially when we thought everybody was getting it rather than just a subset. There was an idea that opioids were suppressing fever in patients who didn't get an epidural, and it wasn't really an epidural phenomenon, it was an opioid phenomenon. But that turns out not to be true. We've looked at this, women who get an epidural with opioids versus without, or who got opioids before their epidural versus without. They all have the same incidence of fever. The thermoregulatory ideas, were ambient temperature of the labor rooms, but it turns out it doesn't matter. Maybe we impair heat dissipation, maybe we increase heat production. There is a little data on that. Here's some data looking at women who had epidurals. All of them did. Some shiver, some don't. You've all seen this, right? And the women who shiver, shown in the open circles, compared to the women who didn't shiver, shown in the closed circles, have very different temperature curves. The women who shiver get more fever. Now, that may be the mechanism by which some underlying process causes them to get a fever, or it may just be a result of some other process, or maybe it is the problem. Not everybody shivers, but we don't know why some shiver and some don't either. So all of these sort of speculative ideas that might be affecting all patients really pale when you consider the fact that only about 20 or 25% of the patients are getting the real temperature increases. And that's led to the dominant theory now about why epidural fever exists in the first place, and that's inflammation. So I'm now going to show you about 4 lines of evidence to suggest that the phenomenon of epidural fever is a phenomenon of inflammation, and inflammation of a special type. So the first line of evidence is that there is a consistent finding of placental inflammation in women with epidurals who develop a fever. This is some study from Dashi and colleagues in Dallas that looked at a group of relatively high-risk patients, and they divided them into patients with epidurals or without epidurals, shown in this table here. And you see on the highlighted columns here that if there was fever and histologic evidence of placental inflammation, there was a strong effect of having an epidural, a big difference between the epidural and non-epidural patients. But if there was fever and no placental inflammation, first of all, that was much rarer, and second of all, there was no effect of epidural analgesia. So this pointed to the idea that placental inflammation somehow is tied to the effect. Now, nobody had any idea, and we still don't, why an epidural might be associated with placental inflammation, but this did point to the placenta as a possible source. Along the same lines, this study by Manny Vallejo and colleagues at Pittsburgh examined their own data retrospectively, and they made the point that in their institution, they don't call fever by itself chorioamnionitis. You have to have fever and a clinical sign, something like tachycardia in either the mother or the baby, or uterine tenderness, or foul-smelling fluid, or maternal leukocytosis. And then they confirmed the diagnosis of chorio by looking at the placentas for inflammation. And here's what they found. If you had a diagnosis of amnionitis and you didn't have an epidural, your incidence of fever was 100%. Well, that's not surprising, even a little bit, is it? Because part of the definition is you have to have a fever plus a clinical sign. The same thing is true if you have a diagnosis of amnionitis and you did have an epidural. By definition, 100% of those patients had fever. But if you didn't have evidence of amnionitis and you had an epidural, the incidence of fever was only 1%, meaning that there's something special about inflammation of the placenta tied with these patients with epidurals that's responsible for the fever. So that's the first line of evidence. The second line of evidence is that systemic markers of inflammation are associated with having an epidural and getting a fever. So this is some data from Laura Getzel, I guess at this time in Houston, Texas. They measured interleukin-6 levels in the plasma of women who self-selected epidural analgesia. And you see here the distribution of IL-6 levels initially at 4 hours and at 8 hours of exposure to an epidural. And you can see this steady rise in average IL-6 concentrations the longer the epidural is in place. Also, they observed that the baseline IL-6 level was higher in women who eventually got a fever, and IL-6 was higher at the time that fever happened in the women who developed fever. So there was strong evidence that that was the case, that there is evidence of systemic inflammatory markers. Now, the third line of evidence is that anti-inflammatory strategies, anti-inflammatory drugs, can suppress epidural-associated fever. So this is Getzel's group again, doing a randomized trial of women who self-selected epidural analgesia being randomized to get placebo or one of 2 doses of methylprednisolone, a low dose, 25 every 8 hours, or a high dose, 100 milligrams every 4 hours. And that's a lot of methylprednisolone if you think about it. They measured temperature, they measured maternal and neonatal IL-6 concentrations, and they cultured the babies just to make sure that this was an okay maneuver. So here's what they found. The first thing is fever greater than 38 centigrade, or 100.4, was in fact suppressed by high-dose steroids. Placebo and low dose were not statistically significantly different, but the high-dose group had almost no fever. The IL-6 concentrations are shown in this graph. Now, this is the cord blood or fetal levels, but the same thing was true in the maternal levels. And you see as you go from left to right on your screen, from the placebo to the low dose to the high dose group, the IL-6 levels progressively decrease. So this is all well and good. The only problem is there was a huge and dangerous side effect, and that is neonatal bacteremia was dramatically increased in the high-dose steroid group. 1 out of 10 babies had bacteremia. It's not really clear what the mechanism of that was, but it obviously makes this an impractical maneuver clinically, but it does point to the mechanism as being an inflammatory mechanism. Similarly, this intriguing kind of study from China looked at the inclusion of epidural steroids in the epidural mixture and found a similar result. This was a study in 78 near-term nulliparous patients who were afebrile requesting epidural analgesia, so this was not randomized epidurals, but everybody had an epidural. And they all received PCA, bupivacaine, fentanyl, but they were randomized to include dexamethasone at 0.2 milligrams per mil in their epidural mixture or just control or saline. Now just think about the math here for a minute. The demand dose is 5 milligrams with a demand, and the background rate is 5 mLs per demand dose, and 5 mLs per hour is the background dose. So they're getting a milligram an hour of dexamethasone plus a milligram every time they push the button. So this is not low-dose epidural steroids. This is a pretty hefty dose. And what they found was a difference in the temperature curve. So you see the control curve and the dexamethasone curves shown here, and there was a little lower temperature in the dexamethasone group. The incidence of fever in this study was incredibly low in both groups. It was 10% in the control and 3% in the dex group, and those numbers were too small to be statistically different for such a small study, but it was in the same direction. And what they found, again, was a reduction in IL-6 levels. So you see here in green the saline patients, and in blue the dexamethasone patients. At baseline, the levels were not different. At full dilation, the saline group had much higher IL-6 levels, and that was also true at the time of delivery. So epidural steroids seem to also suppress fever. Now, at these levels, I'm not convinced this wasn't a systemic effect of the dexamethasone, but it is intriguing that it also worked there. So the fourth line of evidence, and the final one, is that the inflammation that is seen is not the result of an infection. It is a non-infectious inflammation. This is a paper out of Lieberman's group. Laura Riley at MGH was the was the first author. This is a reanalysis, again, of 2 unpublished randomized trials on a completely unrelated topic, on the use of doulas in labor. They looked at 200 women who were low-risk term nulliparous patients who self-selected epidural analgesia, and they measured maternal temperature, IL-6 and 8. And importantly, they also looked at not just placental pathology looking for inflammation, but they also assiduously tried to culture bacteria from the placentas, and they used the polymerase chain reaction to look for ribosomal DNA from bacteria so that they could differentiate it from mammalian ribosomes. So they really tried hard to look for evidence of bacterial infection. So what they found was, first of all, like the other studies, fever was more common in the epidural patients than in the ones that did not select an epidural. And the baseline IL-6 levels, like what had been observed before, were higher in those who eventually developed fever, and the levels of IL-6 and 8 were higher when they became febrile. So all of this inflammatory fever was reproduced in this study. Histologic chorioamnionitis, defined as inflammation, was also more common in the febrile patients, 70.6 versus 27%. But, and this is important, infection was exceedingly rare and did not differ between the febrile and the afebrile groups, about 5% in both groups. Nor did infection seem to be more common in the epidural selecting patients versus the non-epidural selecting patients. So it doesn't mean that when you get an epidural, something happens and you get infected. What it means is the inflammation that develops, and it does develop, is a sterile inflammation. Supporting this idea is this recent trial by Shiv Sharma out of Dallas that looked at 400 nulliparous women who had requested epidurals, and they randomly received either cefoxitin 2 grams IV prior to the epidural placement or placebo, and they too measured temperatures and placental pathology. This graph shows you in the placebo group in the green and the cefoxitin group in the blue that there was no difference in the incidence of fever, no difference, and there was no difference in the incidence of placental inflammation. So broad-spectrum antibiotics given prophylactically could not alter this pattern, but they did confirm that placental inflammation, just as had been seen before, was much more common in febrile than in afebrile patients. Okay, let's just stop for a minute and make sure we all know where we are. So far we know fever is more common in women who get an epidural. It is only seen in laboring women. It is not apparently an artifact or something that happens to all women, and therefore it is not a regulatory temperature problem, and it appears to be due to a non-infectious inflammatory process. So what's the impact? Who cares about this? Why do we have a lecture? Why do I say that it's still a hot topic? Well, it's because fever in labor is not a benign process. There are a number of adverse effects of maternal epidural-related fever. There are some maternal effects. Moms shiver. That's very uncomfortable for some. Not surprisingly, antibiotic treatment of women is increased when this happens because obstetricians rightfully are afraid that there might actually be an infection. Even though we now know it's relatively rare, you still don't want to miss an infection. Also, for reasons that are not 100% clear, cesarean delivery and instrumental delivery seem to be increased in febrile patients, and whether this is an effect on the way obstetricians practice or a direct effect of fever on the uterus is not clear, but you've all seen it, right? She's been in labor for a while, she's moving slow, now she's got a fever, let's take her back, right? You've all seen that. What I'm really concerned about, though, is the fetal effects. The fetal effects are why this talk is in your syllabus. Now, the first fetal effect that was observed was an indirect effect. It was that babies born to moms who had a fever got worked up for sepsis more frequently than babies born to afebrile moms. So this is some data, again, from Lieberman's group in Boston, that, again, a reanalysis of an RCT for a different matter. Patients self-selected epidural or non-epidural anesthesia, and you see here the incidence of sepsis evaluations was about 1 in 3, 34% in the epidural group, and about 10% in the non-epidural group, a relative risk of about 4, an odds ratio of about 4 that was highly significant. You also see that documented sepsis in the babies was vanishingly rare, well under 1%, and did not differ between the groups. This idea was questioned a little bit by this group. This is Call out of the Pittsburgh group again. And they argued that the thing about the Lieberman study was it was a reanalysis of an RCT trying out a new labor management technique, and maybe the neonatologists were a little fidgety to work up babies really, really frequently. So that maybe this wouldn't be true. So they looked at their own data. And in their institution, they said that, you know, you have to have fever and clinical signs to work up the baby, not just a fever. This data shows that the control patients in the open bars versus the epidural patients in the black filled bars had the same temperatures at baseline, but the moms on general were warmer at delivery. The babies were also warmer at delivery, but quickly normalized within 6 hours. And in their institution, there was no difference in the incidence of neonatal sepsis workups, about 10% in both groups or less, no difference. And so I think a lot of us, when this study came out, sort of thought, great, we can forget about fever, and maybe we'll just fade away like Tony and Stephanie. But in fact, it won't. And the reason why is because fever is epidemiologically linked to a number of neonatal brain injuries. There's a number of other more immediate effects of febrile, of babies born of febrile moms. So in the delivery room, lower APGAR scores, lower neonatal tone, and increased need for resuscitation, such as bag mask ventilation, chest compression, or intubation, have all been documented in babies born to febrile moms. In addition, in the first few hours or days after birth, otherwise unexplained neonatal seizures are more common in babies who are born to febrile mothers. And increased NICU admissions, sepsis, and birth asphyxia have also all been documented in babies born to febrile mothers. The really scary thing, though, is long-term neurologic damage. Most of these things maybe you could overcome, a bit of a scare, but maybe not the end of the world. But long-term neurologic injury has been documented as well. So more than 50 years ago, in 1955, an association between cerebral palsy and maternal fever was first noted. More modern studies using modern case control methodology have confirmed this association. Here's one from Grether in 1997 that looked like just fever and labor, whether clinically or histologically diagnosed chorioamnionitis, were all associated with relative risks of cerebral palsy of about 9-fold. Here's another one from Wu and colleagues. If this found that clinical chorioamnionitis, which was as simple as the clinician thinking that there was chorio, was associated with a 4-fold increase in the risk of CP. And a meta-analysis published around 2000 of more than 19 studies in term neonates who developed CP showed the relative risk was about 4.7 if mom had a fever. Other neurologic deficits have also been documented. So neonatal encephalopathy was documented by IMPI with even low-grade fever to be associated with an odds ratio of about 4.7 with maternal fever. Even if the babies look good at delivery, Olaf Damon from Tufts documented that the cognitive scores on standardized intelligence testing at age 9 were more likely to be impaired if mom had a fever with an odds ratio similar, 3.6 to 3.8. And in other epidemiologic studies that we won't discuss in detail, other significant brain injuries such as autism, schizophrenia, and even later in life Parkinson's disease have been associated with intrapartum fever in the mom. Now, we're going to wrap up here with just a little bit of our attempt to try to understand this a little bit better, and I promise not to show you a lot of animal data, but I just want to touch on this very quickly. You can model maternal fever by inducing fever with an infection in an animal. So you can inject E. coli into the cervix or into the intraperitoneum or directly into the uterus. And if you do that in a series of animals, what you find is that compared to just a saline injection, the babies develop white matter lesions in their brain, and that's what some of this data suggests. Now, there's dozens of other studies using similar models, but the problem with all those models is they're infectious fevers, right? And we already know that epidural fever is non-infectious fever. It's something different. So the fact that we can cause an intrauterine infection and mess up the baby's brains is interesting, it's important, but it doesn't help us understand the risk of epidural-associated fever. And that's what led our laboratory to try to develop a model, and this is the work that SOAP is supporting in part. So our model, we take near-term pregnant animals, rats in our case, and we inject them directly with IL-6, very similar to the pattern seen in epidural-associated fever. And I'm not going to take you through this in great detail except to say the two curves on the upper part of this graph here are two different protocols for administering IL-6 at the arrows, and the other curve is the control group that got only vehicle, and you can clearly see a difference in temperature. So we can induce fever with IL-6 in the pregnant animal. Interestingly, we've now found that we can block it with magnesium, and later this year we'll present some data to suggest that clinically women who receive magnesium get less fever when they have an epidural than women who don't. And in this graph, it is the green curve on the bottom that got IL-6 plus magnesium. And you can see that it significantly suppresses fever. I won't show you all the neuroscience, but we can show inflammation in the fetal brains of babies that are exposed to IL-6 in the mom versus babies that mom gets saline only. So we can induce an inflammatory process in the baby's brain. And what we're now attempting to investigate is whether there are any functional consequences of this, and that's what SOAP is going to help support. I'm just going to show you two exceedingly brief video clips just to give you an idea of the phenomenology we want to study. So this is a group of juvenile rats. They're about not quite a month old. They were born to a mother that received saline injections. I'm just going to play a few seconds of this. Now what you want to see here is they play. They jump all over each other. There's mounting behavior. There's oral, anal, and oral genital contact. They're fidgety, they're curious, they run all over the place. This is what juvenile rats do. Okay. Now, this is a group of animals that the mom received IL-6. And this is what they do. They kind of sit around. They don't really interact with each other. They don't look at each other. They don't do those social interactions that are so typical otherwise of juvenile rats. Now, when I showed this to an animal ethologist who's done a lot of work on psychiatric disease models in animals, said, this is exactly what models of autism look like. So we don't know whether this is going to turn out to be a real deal or not. We're also going to be studying their maze learning capabilities and hippocampal function and so forth, similar to what's been done with general anesthetics. But this is the kind of thing that scares us a little bit and why we think this is, in fact, a hot topic and something to be pursued by us as the obstetric anesthesia community. Very briefly to wrap up, we don't know how to block this. Acetaminophen does not work. It's a pretty good antipyretic if you have a virus, but it's a lousy anti-inflammatory, and unsurprisingly, it failed in a randomized trial to suppress epidural fever. Opioids have a very weak effect. Steroids work, but at a great cost of neonatal bacteremia. And as I mentioned, magnesium might work. Other drugs that have been proposed to be studied are things like statins or nonsteroidals, or even N-acetylcysteine. So to sum up, just the facts, ma'am. Epidural analgesia is causally related to maternal fever. It is not an artifact. The most likely cause is a sterile inflammatory process. Maternal inflammatory fever is indeed causally related to neonatal brain injury in animal models, and it's epidemiologically linked in humans. And what makes me nervous, like Edward Munch's The Scream here, is we don't know if labor epidural analgesia in and of itself can cause inflammation. That's bizarre. We think of epidurals as anti-inflammatory. We don't know if epidural-associated fever in the absence of any maternal infectious process can actually cause neonatal brain injury, but I'm scared to see what the epidemiology might show. I believe it will be connected, and we have no way to safely suppress it yet, and I think the search really should be on for that. So I'll leave it there, and I'll thank you very much.